Thank you, Mr. Chair and members. I'll go ahead and start while some of the folks who are supporting this bill also join me here. I accept the amendments suggested in the analysis first and foremost, and thank you for your help and guidance. Individuals with chronic conditions are greatly impacted by health plans and insurance reliance on cost containment policies, including prior authorization and step therapy. Fortunately, thank you. Then let me just get to the heart of the issue. Existing law requires all health plans and insurance to maintain an exception process and a grievance system to consider and, if appropriate, correct an enrollee's grievance. Last year's new federal regulations inadvertently created an inequality in how exception requests for non-formulary and formulary prescription drugs are treated. And so hopefully with this bill, this is going to attempt to try to fix that. With me, I have Kristen Herr with the Arthritis Foundation, as well as Dr. Mizutani. Thank you for both.
Thank you, Assemblymember. For the record, Kristen Herr, Arthritis Foundation, the proud sponsor of this bill. The Arthritis Foundation represents more than 5.9 million adults in the state of California, as well as 300,000 children with doctor-diagnosed arthritis. And the patients that we serve, who you will hear shortly from Dr. Mizutani, often experience barriers in the care that lead to serious and irreversible joint destruction and deterioration of their condition. And often our patients are taking complex biologics that treat these complex conditions. And without these medications, they have very real delays in their care. I'll keep my comments short. We do have Dr. Mizutani to highlight one case that this bill would have had a better outcome for the patient, and I'll be here to answer any technical questions that you may have. So with that, I'll introduce Dr. Mizutani.
Thank you. Doctor?
Thank you, Kristen. I'm Wesley Mizutani, rheumatologist, and I work with the Arthritis Foundation as a board member. The best way I can illustrate how what may seem as a trivial delay in care actually results in jeopardizing the well-being and functioning of patients is to present an actual patient case. I had a young female patient of mine who had very serious lupus with kidney and lung disease, lung involvement, and had been hospitalized because of her worsening kidney disease. And so while in the hospital, she received chemotherapy, which is one of the treatments for serious lupus, and she received subsequent chemotherapy as an outpatient for about 6 months. The routine is that once we reach a remission, which her renal function returned to normal, is we switch them to an oral medication. So we attempted to switch her to an oral medication. However, we were surprised that it required a prior authorization, after which it was denied and we had to go through an appeal process. In the meantime, and that process took about 6 weeks to 7 weeks to complete. In the meantime, the patient had to end up back in the hospital because the last time she had chemotherapy was 6 weeks prior. She ended up with more renal dysfunction, had to actually have an acute dialysis done, and then was put back on the chemotherapy. The reason we didn't put her on the chemotherapy for long term is because of the effects on the ovaries as well as the bone marrow. So we wanted to switch her to oral medication that would spare those. However, she ended up getting it again in the hospital to again get her kidneys back to a reasonable normality. So I bring this up because if a process was in place that would allow her to get that medication sooner, she wouldn't have ended up in the hospital. She wouldn't have had another chemotherapy to sacrifice her ovaries and her bone marrow suppression. And so I'm in support of AB 2400 for that purpose.
Great. Thank you very much. Appreciate that. Others in support? Just your name and organization, please.
Thank you, Mr. Chair and members. Fred Noetwer representing Pharma in support.
Linda Way with Western Center on Law and Poverty in support.
Greg Herner on behalf of the California Life Sciences Association in support.
Howard Chang on behalf of the National Psoriasis Foundation in support.
Any others in support? Okay, and then we'll go ahead and bring up those in opposition.
Thank you, Mr. Chair and members. Nick Luizos on behalf of the California Association of Health Plans in opposition to AB 2400 because it goes beyond already confusing federal regulations. We believe it sets a bad precedent in how California deals with grievances. It will load new administrative costs onto the health plans at a time when we really need to be conscious about affordability in the health insurance market. And in our view, it's designed to compel the coverage of costlier drugs when more cost-efficient alternatives are on the market. So just by way of background, California for several years has had a system in place to deal with grievances. Enrollees have access to an independent medical review, or IMR, administered by the state and is funded by the health plans, where if there's a dispute over the medical necessity of a covered service, there can be an alternate or independent review of that dispute. Before an enrollee, according to the law, can have access to this IMR process, the enrollee first must file a grievance with the plan to see if that agreement can be resolved before moving to the independent medical review system that's run by the state. That system and the turnaround times associated with this grievance process are the same for any covered service, whether it's a transplant, cardiac arrest treatment, or any other covered service, including on-formulary prescription drugs. If the grievance is filed as an expedited review, the plan has only 3 days to respond to that. That is the current timeline. And we believe that's an absolutely reasonable timeline, particularly when you consider drugs that may have serious or harmful side effects for the patient, or where are the concerns over addiction or drug abuse, or if there's a generic on the market that's available that will do the job for much less. It's the health plan's job, of course, always to make sure that we're investing premium dollars in good care. This bill is asking us to treat covered prescription drugs differently from every other service and to obtain a result for the enrollee within a very tight 24-hour time frame under emergency circumstances. We believe that this is an overly aggressive time frame and will lead to one of two bad results in our view. One, the plan medical directors that are reviewing the case may be compelled to just cover the requested drug even if it's inappropriate for that particular person, or even if it's wildly expensive compared to other alternatives that are on the formulary. Number two, the likelier result is that the plan will just deny more requests due to the lack of time and information and then send more and more requests to the independent medical review system that's run by the state. And that would be an unfortunate outcome from our perspective, since many grievances can be resolved between the health plan and the enrollee without going to independent medical review. According to the Department of Managed Healthcare in its 2013 Independent Medical Review Summary Report, about 23% of cases that qualified for an IMR were resolved without the independent medical review, and those were resolved, through the internal plan grievance process between the enrollee and the health plan. So, from our perspective, the IMR process should really be reserved for actual disputes and not issues that could have been resolved beforehand if adequate time was given for the health plan to reconsider its initial denial or modification of the service. Just one last point, Mr. Chair. The IMR process is actually very expensive. One of my plans tells me that an expedited request costs $3,000 per case. Non-expedited request is about $1,500. And to the extent that this bill results in more and more cases going to IMR, it's going to increase administrative costs for the plans at a time when we really need to restrain costs in the healthcare system. So, thank you.
Thank you.
Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies. We too are in opposition to the bill. I think our main concern is over the last several years we've seen more and more bills introduced to sort of segregate out prescription drug benefits and create a higher and uniquely different process for them than all other covered services. This creates an incredibly tight time frame of the 24 and 72-hour time frames. We often see, several years ago, we had another bill that was introduced on prior authorization, which created similar time frames. We've seen from that sort of a frustration of the conversations through the regulatory process about the inability to pend something depending on whether or not you need additional information. Sometimes it really is about whether or not you need something additionally from the doctor or you need other information to process that request. And it's a way that there's a check and balance there for the plans to make sure that they have all the information to appropriately approve that request. So now we're creating another arbitrary sort of shortened time period, and the worry is that we are going to inadvertently be in a situation where we're denying requests that otherwise could have been resolved through the internal grievance process and then pushing insureds to go through another IMR process. And that's sort of counter to what we want. We want the IMR process to remain about really significant disagreements about coverage, not about collecting additional information. And the information that we're looking at, I just want to point out, can be incredibly important. It can be a monitoring program for certain prescription drugs that there's a lot of abuse or concern about adverse effects on the patient. So these are all sort of things that we look at, and I think we're continuously concerned about shortening up these timeframes to unworkable and costly requirements on the plans that inevitably will have less advantageous benefits to the consumers. And so for those reasons, we're opposed to the bill.
Okay, thank you.
Thank you. Mayor Morton here on behalf of the California Chamber of Commerce, also opposed for the reasons stated, but just concerned about balancing the potential benefit to enrollees. We understand wanting to have common rules, but always at what cost? And here we see a number of different ways this could drive up costs for purchasers, and the benefit to enrollees is fairly minimal. I know we just had an example that was a pretty extreme case where you did have harm come to the patient, but I think actually current law addresses and current regulations already address that you shouldn't have a 60-day time period in that sort of situation. So we believe the protections from that are adequate. This is really about, are we going to have 24 hours or an adequate amount of time for the agency, for the plans to do this? And if we try to expedite that, we're going to either have them staffing up, approving drugs they don't need to approve that are unnecessarily being approved, or potentially being fined by the agency for not approving them in a timely manner. So we oppose. Thank you.
Okay, thank you. Others in opposition, just the name and organization, please.
John Caldwell on behalf of PCMA. It's the National Trade Association for Pharmacy Benefit Managers. They're also opposed.
Allison Ramey with Blue Shield of California in opposition.
Great, thank you. Anyone else? I'll bring it back to the committee for questions. Questions from anyone? Roger? Excuse me, Mr. Hernandez.
Wow, so informal these days.
I apologize.
All right. We're friends. So, Mr. Nazarian, I strongly support your bill here today. When health plans deny coverage of prescription drugs, patients, we do know that they have a right to a speedy investigatory process to make sure that they're able to appeal and get the drugs. But it seems to me these days, when I talk to my consumers, when I reflect on my own personal and family experience, these delays are causing patients who need medications to wait longer than they should. And as a result, what I've seen is that some people have been left without the card of a permanent consequence, and that should not be the case in the world of healthcare. That's not the kind of healthcare that our communities are striving for. So I stand with your focus here and your desire to bring healthcare that turns around quicker, that stands on behalf of the patient, and not with the for-profit organizations that are here before us. I understand that there is managers in place with insurance companies that look for cost containment in this process. But at the end of the day, we all spend a hefty dollar per capita. Nowhere in the state in this country does individual pay more for health care than in the state of California. And I think that when you look at the health conditions that we live with here in California, so many of the realities, the levels of poverty and the correlation that it has to do with access to health care and the correlation that has to do to wait times, it's ridiculous. So I'm really proud of the fact that a colleague of mine is standing up for the patients here. And I'd like to stand with you. I'd like to ask to be added on as co-author. I would be honored to be added on. And you have my support. Thank you for doing this.
Thank you. We'd be honored to have you.
Thank you, Mr. Hernandez. Ms. Waldron.
Thank you, Mr. Chair. Great author, by the way. I do want to say that I've had many bills similar to this, trying to deal with prior auth issues, appeals, shortened appeals, urgent appeal, time reductions from 72 hours to 24 hours, and things like that. And as it's gone through the process over the last 4 years of all of these bills, we've had to narrow our focus quite a bit. A lot of times my bills would start out with a select number, and then they'd have to be reduced to one just to get through the process because of the costs. So my concern with this bill today is that it's kind of like a fire hose approach. I know I agree with the philosophy of it, of trying to get folks, the urgent appeal, trying to get them the prior auth process through quicker. However, I think there's just no limit on which drugs, how many disease states, the amount of people that would be going through it. It might be an overload at this time. So I just think I'm going to sit back and wait and see how this goes through the process. And I won't be voting today, but I want to see where it goes.
Okay. Anyone else? Any other questions? I have a couple questions. First is, and maybe for Mr. Luisos and or someone else there at the table. There's no pushback on the non-formulary, but there is on the formulary. So the non-formulary has these guidelines already. Can you explain why no pushback on that, but yet pushback on the formulary, which is already part of the plan?
Well, thank you, Mr. Chair. Actually, if I had time, I may have pushed back on that part a little bit more as well. With respect to the non-formulary drugs aspect of it, the federal regulations that have been issued on that subject are very recent. And actually, we have a lot of questions about how that process is going to work. We still have some outstanding questions that we're working with the Department of Managed Healthcare on about how that federal process is going to fit in with the existing internal grievance processes the plans have. What the federal regulations did is they established a third-party review of non-formulary drug cases, which we just have a lot of concerns with and are working with the department on. So we do have concerns with that area. We're not sure that the bill's approach is the right approach on that, and we're still just trying to figure it out with CMS and with the Department of Managed Healthcare.
And then my second question is, do the plans really need 30 days?
Mm-hmm. So the 30-day wait time or turnaround time is actually for non-emergent or non-emergency related issues. Again, the emergency timeline is 3 days. Many of my plans said that oftentimes cases are resolved within the 30 days or before the 30 days hit. I don't know what the percentages are, but it's not a system where where it's about waiting for the 30 days to come up or not. It's really, if you can resolve the case earlier, it'll be resolved frequently. So,
okay. Thank you very much.
Yeah.
So we have a motion on this. We have a motion on this. Have we heard a motion on the bill? We have a motion, and do we have a second? There was a second. Was Mr. Hernandez? Okay. My apologies. I'm a little slow here. So we have a motion to do pass as amended to appropriations. So at this point, we'll go ahead and call for the roll.
Wood?
Aye.
Wood, aye. Mainshine?
Aye.
Mainshine, aye. Bonilla? Burke? Campos? Chu? DeBobne? DeBobne, aye. Gomez? Hernandez?
Aye.
Hernandez, aye. Lackey?
Not voting.
Lackey not voting. Nazarian?
Aye.
Nazarian, aye. Olson? Patterson? Patterson, no. Ridley Thomas? Aye. Ridley Thomas, aye. Rodriguez? Aye. Rodriguez, aye. Santiago? Aye. Santiago, aye. Steinorth? No. Steinorth, no. Thurmond? Waldron? Waldron not voting.
Mr. Nazarian, your bill has 8 votes. You need 2 more and 2 opposing at this point, so we will hold that on call. Do you want to announce that item number 5, AB 2076 by Mr. Calderon, has been removed from today's hearing agenda at the request of the author? So we will now move on to the final bill of the day, which is Wood, AB 1863, and I'm going to turn this over to my Vice Chair, Mr. Mainshine.
Thank you, Mr. Chairman. You may proceed.
Thank you, Mr. Chair and members. AB 1863 adds marriage and family therapists to the list of healthcare providers that qualify for a face-to-face encounter with a patient at a federally qualified health center or rural health center for the purposes of a per-visit Medi-Cal payment under the prospective payment system. Marriage and family therapists are already recognized as Medi-Cal providers and are able to provide care in county health plans, Medi-Cal managed care plans, and as Medi-Cal fee-for-service providers. This bill brings parity throughout the Medi-Cal delivery system by allowing reimbursement to clinics for their visits. Behavioral health and substance abuse services are part of the essential health benefit under the ACA. The inclusion of these services under ACA dramatically expanded coverage for millions of Californians. There are approximately 600 federally qualified health centers and 350 rural health clinics in California. They are largely nonprofit community clinics that provide and safety net providers and make their services available regardless of a patient's ability to pay. Their continued survival depends heavily on the stability and adequacy of the Medi-Cal revenue. In my district in Northern California, clinics are not just a safety net. They provide a significant portion of the primary care received by many of my constituents. As much as 50% of the care for patients in my district is provided by a federally qualified health center or a rural health clinic. Within a primary care setting, research indicates that up to 26% of patients have some mental health disorder. There's clearly a need for these services in clinics both in my district and throughout the state. Here in support of the bills are representatives from the sponsors, the California Association of Marriage and Family Therapists and California Primary Care Association.
Thank you. Mr. Chair and members, Tim Shannon, representing the California Association of Marriage and Family Therapists. This is identical to a bill that Dr. Wood carried last year that got to the governor. It got there without a single no vote in the legislature. It was vetoed along with 5 other Medi-Cal bills because the state of funding for Medi-Cal, according to the governor at that point, was not stable. We believe with the MCO reform that was recently passed, we may have a better chance this year, so we urge your aye vote. I'd like to introduce our witness who can answer questions as well, staff counsel for the association, Sarah Cashing.
Good afternoon, Chairman, members of the committee. I just want to say how proud we are to be co-sponsors of this bill and to really emphasize that this is about improved access to care in areas where there is a particularly great need. Studies show that qualified mental health professionals are especially needed. There's a severe shortage in these rural areas, and studies show that marriage and family therapists tend to be the behavioral health professionals that are the most prevalent in these areas. The studies come from the Center for Health Professionals as well as journal articles in the Journal of Rural Psychology. They support, again, the assertion that MFTs are available in these areas, and we can show from our members' surveys that they are poised and ready to take on these important positions.
Thank you. Further witnesses in support, name and organization only, please.
Chair and members, Sean South with the California Primary Care Association.
Thank you.
Mr. Chair, members, Fred Notwer, representing the American Association for Marriage and Family Therapy, California chapter, in support.
Mr. Chair and members, Paul Yoder on behalf of the San Joaquin County Board of Supervisors. Urge your aye vote.
Kelly Brooks on behalf of the Santa Clara County Board of Supervisors and the Association of California Healthcare Districts, here in strong support.
Michelle Gibbons with the County Health Executives Association of California, in support.
Any further witnesses in support? Seeing none. Witnesses in opposition?
Hello, Mr. Chair and members. My name is Rebecca Gonzalez. I'm the Director of Government Relations for the National Association of Social Workers California chapter, and we are opposed to this bill. We're opposed for several reasons. One reason is that we believe that the supply of social workers is there in these communities. Right now, every year, we have 10,000 social workers in the state that are graduating from BSW and MSW programs. We also have social work schools in 2 UCs and 2 UCs and 23 CSUs in the state, including in rural areas such as Humboldt, Fresno, Bakersfield, Fresno. Also, USC has started a very extensive online social work program in the state with 2,000 students, 200 of which live in rural areas, and Long Beach State also has a rural program. Secondly, these clinics serve a community that's very diverse and impoverished, and social workers are specially trained to work with these communities. We work with the person and the environment so that we look at the pathology of a mental illness and provide clinical services, but we also look at the circumstances that these patients, clients come from, and we look at the special circumstances, the discrimination they might face in the community, and we work to find them other secondary services that are very important for their recovery. So, for example, if you had a homeless person who had a mental illness, if you only treated the mental illness but you didn't help find them a home, they wouldn't stay stable. And so social workers have been working in these community settings for a very long time because they are extensively trained in these areas. We also have a graduate internships where students are further trained in these areas. Also, lastly, there was a bill passed last year by Senator Hernandez that was trying to reform the way the payment system works in these clinics, and there is broad interest in this reform and expanding it to other areas. And so for that reason, we also think this bill is not timed well. That concludes my remarks. Thank you.
Mr. Chair and members, Amanda Levy on behalf of the California Psychological Association. We also find ourselves in an opposition role for this bill this year. Psychologists, again, our numbers, we believe they're there as well, graduating high numbers of students from state schools and from professional schools or psychology, and are setting up in the last year even many more integrated healthcare models, which the clinic model fits perfectly. So we've been setting up many more internships, and we think the numbers will continue to grow. Students are reporting they want to be in this type of environment rather than the traditional 1 hour psychotherapy one-on-one client. So we're seeing that change already since the adoption of the ACA, and especially in the last couple of years. Psychology programs are able, with a longer amount of time at the doctoral level, you're able to kind of get the survey of everything, but then you kind of have one or two specialties or tracks kind of emphasis. And those best qualified to work in these clinics would probably have an emphasis in either health psychology or neuropsychology. And cases in primary care, as we've seen, may initially seem straightforward, are often more complex with a combination of the medical, psychological, social, or maybe substance abuse medicine-induced, and are better diagnosed and treated by a more qualified, trained clinician at the doctoral level, which is why we're in clinics right now. The master's degree requires 3,000 hours of supervised professional experience for psychology graduates and students to be competitive. It's about 5,000 hours of internship and then postdoctoral studies. And then with more, in addition, another 3,000 hours of supervised professional experience. So about 8,000 to 9,000 hours, almost 3 times as much as some of the clinicians that we see are trying to be added here. So with that, I'll conclude my remarks and take any questions if there are any.
Thank you. Any further witnesses in opposition? Seeing none, questions or comments from the committee? Mr. Patterson.
I guess we had one last year, 80-0. The governor vetoed it. Mm-hmm. What is your expectation? Have there been conversations with the governor's office?
We have.
Have you made progress?
I believe we've made progress. We had conversations. The reason it was vetoed is I was one of 5 bills that were vetoed with the same veto message was essentially that until the Medi-Cal funding for the program was stabilized, he wasn't inclined to sign any bills that would expand for payment. So we did that just recently. So I hope that we will get his signature this time.
Any further questions or comments from the committee? Seeing none, Mr. Wood, you may close.
Yeah, I would just like to say, this is not a debate about the qualifications of providers. That's already been established. These are already existing Medi-Cal providers. All this bill actually does, is allow for them to bill in a federally qualified health centers. They can already do this for the counties. They can already do this as Medi-Cal plans. They simply can't do it in a federally qualified health center or a rural health center. So that's all we're asking for. We're not talking about qualifications and suitability. And trust me, if the supply matched the demand, I wouldn't be here today. We have a huge demand in rural California. We have spots that cannot be filled, and so I am moving this bill to try to help out my constituents and probably many of yours. So I respectfully ask for your aye vote.
Thank you very much, Mr. Chairman. We have a motion and a second due pass to appropriations. I'd ask the clerk to please call the roll.
Wood?
Aye.
Wood, aye. Mainshine?
Aye.
Mainshine, aye. Bonilla? Bonilla, aye. Burke? Burke, aye. Campos? Campos, aye. Chu? Chu, aye. DeBobney? Gomez? Hernandez? Hernandez, aye. Lackey? Lackey, aye. Nazarian? Olson? Olson, aye. Patterson? Patterson, aye. Ridley Thomas? Ridley Thomas, aye. Rodriguez? Rodriguez, aye. Santiago? Santiago, aye. Steinnorth? Steinnorth, aye. Thurmond? Thurmond, aye. Waldron? Waldron, aye.
Your motion passes 16-0.
Thank you very much. Appreciate it.
That's it, right?
Okay, we've got a few bills to catch up on here with some folks. So we're going to start. We'll start with our.
These two are on call.
Okay.
You can lift the call when you get to those.
Okay, we can start with our consent calendar. Allow our secretary to roll through the consent calendar. She's here. She's here. Roll away.
Bonilla? Bonilla, aye. Burke? Oh, I'm sorry, I have you. Campos? Campos, aye. DeBobney? DeBobney, aye. Hernandez? Hernandez, aye. Nazarian? Patterson? Patterson, aye. Santiago? Santiago, aye. Steinnorth? Steinnorth, aye. Thurmond? Thurmond, aye. 18-0.
That motion passes 18-0. We're going to move on to the bills on call. AB 2125, Mr. Chu's bill. I'm sorry, I'm going to lift the call on 2125. Excuse me. Still trying to figure this out.
Bonilla? Bonilla, aye. Campos? Campos, aye. DeBobney? DeBobney, aye. Hernandez? Hernandez, aye. Nazarian? Patterson? Patterson, aye. Santiago? Santiago, aye. Steinnorth? Steinnorth, aye. Thurmond? Thurmond, aye.
Okay, that passes 18-0. We'll move on. I'm going to lift the call on AB 2400, Nazarian.
Bonilla? Bonilla, aye. Burke? Burke, aye. Campos? Campos, aye. Chu? Chu not voting? Gomez? Olson? Thurmond? Thurmond, aye. 12-2.
That motion passes 12-2. So we're going to roll through the others then?
Mhm.
Okay, we're going to roll through the other bills. Everybody was here for 1863, so no? We'll go through 1863 then. Who was missing?
DeBobney? DeBobney, aye. Gomez? Nazarian?
Okay. We're at 17-0 on that one. 1947, Mr. Chu's bill.
Oh, yeah, okay. Bonilla? Bonilla, aye. Campos? Campos, aye. DeBobney? DeBobney, aye. Hernandez? Hernandez, aye. Nazarian? Patterson? Patterson, no. Santiago? Santiago, aye. Steinnorth? Steinnorth, no. Thurmond? Thurmond, aye. Waldron? I'm sorry, not voting.
That bill passes 15-2. Moving on to AB 2053, Gonzalez.
Bonilla? Bonilla, aye. Campos? Campos, aye. Chu? Chu, aye. Hernandez? Hernandez? Hernandez, aye. Nazarian? Santiago? Santiago, I. Thurmond. Thurmond, I. And these ones have already passed.
So that's 18-0. That's the final. That's a vote on that one. Mr. Lackey's bill AB 2341.
Bonilla?
They were accepted. Correct.
Bonilla, I. Burke? Burke, I. Campos? Campos, I. Chu? Chu, I. Nazarian? Olson? Olson, I. Santiago? Santiago, I. Steinnorth? I'm sorry, Thurmond? Thurmond, I.
So that's 18-0. And then the final bill, AB 2636, Mr. Linder.
Bonilla? Bonilla, I. Burke? Burke, I. Campos? Campos, I. Chu? Chu, I. Gomez? Thurmond? Thurmond, I. 18.
That also passed 18-0. So we will hold the roll open for a couple of minutes for Mr. Nazarian to come back, and otherwise we're done.